What's Kelsey? All right. What
I
do you-
already texted her, but,
All right.
oh yeah, she's coming. Tell her to be.
Just want to see.
You have an extra pencil? I'll give it back.
You want one? Sure?
I'm just gonna steal your pen.
No, it's okay.
Oh, this is a good pen to steal.
So the only thing I'm gonna ask is, if you have to take a phone call or whatever, just step out, so not to distract anybody, because I know phones can be very distracting. So I don't want anybody to be or distract somebody else. And then, if I feel that something's really an important point, I'm gonna repeat it a couple of times, all right? I just want you to get it in your head, because with repetition is how you're gonna remember this, right? And for the ICU nurses, a lot of this is going to be review for you, but for my cath lab nurses, this is gonna be new information. So, are we waiting for just Kelsey?
I'm
Right.
reading that.
All right, Kelsey. So I want you to remember a couple of things, and this is one important point right now that you're gonna remember. I want you to remember the principles of supply and demand, okay? Remember supply and demand. It's like anything else in life, okay? You get paid, the money goes in the bank. That's your supply. Now what's your demand? All your bills and blah, 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 blah. Now, if you spend more than you make, then your demand is higher than your supply and you're in trouble. Same thing. The heart, body, supply, and demand. If the heart is unable to perfuse the body and give it what it needs to perfuse all the major organs and have you breathing, walking, moving, talking, then we're in trouble, right? So that's what we want to do. We want to make sure we are able to establish the proper supply and demand, right? Okay. This applies to all parts of life. All right, we're gonna start, so these guys can catch up. So, this presentation doesn't change from, this is the same presentation that I used to do 35 years ago for the balloon pump we had then. That was nearly, I'm not joking, 3/4 the size of this table. So the only thing that does change is the technology of the balloon, but not the theory behind it or what we're trying to achieve, okay? So again, this, if you look back to an old textbook about intra-aortic balloon pumping, it's gonna tell you the same thing, all right? So remember, the principle doesn't change, the machines change. They get updated, they get nicer, it's a touch screen, they have all the bells and whistles, they have all the defaults for if something goes wrong, which is great. But I want you to remember the principles behind it so you understand the other piece. So, cardiac anatomy, the 3 principles are blood is gonna move forward, valves are gonna open, and blood moves by a pressure gradient. So what does that mean? So, pressure is gonna go from an area of higher concentration to lower concentration. And when a pressure builds, right, picture in your head, pressure building and something locked to get you to the other side. And until that pressure builds enough to force that door open, it's not gonna go. So that door that we're talking about to open are the valves. So the pressure in the heart is gonna build from one area to another to open up the valves to then equalize the pressure. So remember, we're talking about moving blood forward and getting past a pressure gradient. You good?
Yes.
Very good. Thank you, ladies. Now, this is what we were talking about with the balloon, okay? Cardiac cycle. That balloon is going to inflate and deflate when it sees a cardiac cycle. And the cardiac cycle is made up of an electrical event and a mechanical event, right? So, question, can you have one without the other?
Yeah, sure, why not?
You're guessing. Yeah. I see Kelsey going, yeah. No. Yes, you can have electrical without mechanical, but does the heart pump? No, right? If you have pulseless electrical activity, right? We see that dysrhythmia. We can have electrical without mechanical, but the heart's not pumping, so it's of no use. That's like turning on the ignition in your car, but the engine won't start. The ignition is the electric and the engine is the mechanical, but you're not going anywhere. Can you have mechanical without electrical? No, you cannot. You need an electrical impulse to simulate what's going to happen mechanically. So yeah, I can have a rhythm with no pumping, which really means nothing's happening, right? But I can't have an arterial pressure or a mechanical event without an electrical stimuli. Good? So when we think of diastole, what do we think of? When we say the heart's in diastole, we think of relaxation, right? Relaxing, exactly, ladies. We think of the heart relaxing, and we think of the heart getting blood, and we think of all these things happening. Isovolumetric relaxation, right? So what happens during this time is the atria are the ones that are gonna get the blood, and that pressure is building, right? And we're waiting for that pressure to be great enough to do what? Open up the valve. Remember, we said blood's gonna move forward. So that's what we're waiting for. And then while the ventricles are filling, right? Now, so now we push those valves forward. And I want you to think of it as in simple terms, because it is simple to think of, right? We can make this as complicated or as simple. We're gonna make it as simple because that's what it is. We're gonna push that blood forward and the ventricles are filling. And as the ventricles are filling, the atria will contract. What I want you to remember here is when the atria contracts, it is going to contribute 20 to 25% to cardiac output, right? How do we know on an EKG or a strip that the atria contracted? A P wave, right? The reason that I want you to remember this, because if we have a patient who is compromised, and when I say compromised, I mean he's had an injury to the myocardium, right? Something's going on, whatever. He's gonna rely on everything to get that cardiac output, right? We're gonna talk about those components. But if I have a dysrhythmia that no longer has P waves, right? I lost 20 to 25% of my atrial depolarization, also referred to as my atrial kick. So we can't afford to have that, right? Not in a person who is already having ischemia or infarction or an unstable angina. We can't afford to lose, or someone who's got cardiomyopathy, or you can't afford to lose that 25%. So I want you to remember that atrial contracting is not only is this mechanical event happening where the pressure is getting greater in the atria, pushing the valves forward into the ventricle, but that atrial contraction is going to assist in our cardiac output, the stroke volume, and what the patient is perfusing, okay? So, here we go, another little picture. Isovolumetric relaxation, the valves are closed, the ventricle pressure diminishes with myocardial relaxation. So, yeah, we're hoping that all the At this point, everything is equalized until the pressures in the atria get higher and felt forces open the valves. And you have all these little pictures, and I'm sorry I had to do this double sided, but I was told I have to save paper, and I don't want to be responsible for the hospital, you know, being in the red because I used too much paper. So here's the part where the ventricles fill, the atrial pressure overcame the ventricles, which means it forced the valves open and the blood moves forward. I want you to remember that too, because there's times if a patient has had a big MI where we don't want the blood to move back, right? We always want it to move forward. And there's times when in a state of either an MI or patient's got other issues where the valves aren't functioning too well and the blood moves the other way, and we don't want that, right? We want blood moving forward. Yeah. And here you go. Here's your atrial contraction. And we said 15 to 25% of the total ventricular volume, it contributes to that. So that's your atrial kick. That's what I'm contributing. That's what the atria are contributing. So the atria, the pressure within the atria is not as muscular as the ventricle, because the ventricle is what's pumping out to the body, right? So the atria are not, but the atria contribute 20 to 25%, which is a huge difference in someone who's compromised. Now, systole. When we think of systole, what do we think of?
Contraction.
A contraction. We think of a ventricular contraction, right? So, you see this part here, isovolumetric contraction. Everybody thinks, so now what's going to happen is the myocardium needs oxygen to do all these things that it's doing, right? And the myocardium is going to get oxygen from the cardiac vessels during diastole. So obviously if my vessels are compromised, I have blocks, plaques, you name it, or complete occlusion, this is all compromised. So we think of systole and we think of the ventricles are going to pump. But you see isovolumetric contraction, that is the phase of systole that requires the highest myocardial oxygen consumption. And here's the reason why. Because tension is building within the ventricles. That tension is building so the ventricles can pump out to the system, out to the body, to the organs, what the cardiac output and stroke volume is going to be. So isovolumetric contraction is where most of your myocardial oxygen consumption, like 90%, is used to get that pressure. So now if you got a ventricle that's, let's say my patient had a big anterior wall MI, what do you think is going to happen? Yeah, it's not going to be working as well because I'm working with less muscle, right? I'm working with less muscle. So now, I'm working with less muscle. So now, yeah, I'm going to have tension build and myocardial oxygen consumption, but I already got a problem. So now I have a big problem here because, and in end result, what's going to happen? Stroke volume is going to drop, cardiac output's going to drop, right? Because I have an injured muscle. So again, isovolumetric contraction is the highest myocardial oxygen consumption in the systolic, in the systolic phase. Then we have rapid ventricular ejection. So boom, out. Blood is coming out of the ventricles, and guess what? It is pumping to the body, and then reduced ventricular ejection, which is the remainder of the blood that's in the ventricles. So that's one cardiac cycle. The blood comes from the body, right? Goes to the heart, the atria, the pressure builds in the atria. Boom, they open up the valves, the pressure goes to the ventricles. Some of that blood goes to the lungs for oxygenation, and the rest to the rest of the body, right? All pressure gradients and all blood moving forward. Remember, we don't want anything moving backwards, okay? Just blood moving forward. So if you have mitral regurg or the valves are injured as a result of an MI because the valves are held by the chordae tendineae here, and if they rupture, then you got a problem. And you will know this by the world's loudest murmur. Like you will hear a murmur that is so loud on someone who has an injured mitral valve as a result of an MI. But those things won't allow the blood to go forward because they're regurgitating back. So remember, blood moves forward, pressure pushes the valves, and we elicit a cardiac cycle, which is going to be the outcome of that, and the holy grail, if you want to call it that, is going to be your stroke volume. What are you putting out in stroke volume, right? Questions? Ladies on the other side there? Oop.
No questions?
What did I just do? Oh my God, I lost it. Ay, 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 ay.
I think it's the first one over there, no?
No.
Oh, the other one, the first one?
No, the first one.
To the left, that one, no?
No, I think it's.
Might be on the different browser. You have two browsers on the bottom. Try hovering on your
Oh, yeah. I can't see.
Microsoft.
Hold
Yes.
on.
Try hovering down there and go to the second window.
Oh, yeah. Thanks, Sam. All right, so we talked about this isovolumetric contraction. We said the left ventricle must overcome the aortic diastolic and diastolic pressure. So the left ventricle has to overcome the afterload. And remember, we mentioned this upstairs, that the balloon pump, so we'll talk about this more, about what the balloon pump is trying to do. So imagine you have a lot of resistance, pressure's really high in the aortic and diastolic pressure, and the ventricle has to overcome that. Who would you think, what population of patients has to overcome that? And you have a lot of them. Just a lot of who? Not, heart failure is more acute, but who's more chronic?
You mean
I have to overcome a higher pressure, higher resistance. Hypertensives,
yeah.
right?
Yeah.
Hypertensives do, because the systemic pressure is higher. So what, in the end, what happens? So you brought up a good point there, Kelsey, because if I have an acute MI, and now because of it, my afterload is up, then it is an acute episode. My body has not compensated for this. So I'm gonna be more symptomatic. But if I'm hypertensive, and I've been hypertensive for years, right? This is not something that people are hypertensive, they're hypertensive, and if they're not controlled, So what happens? What does the heart do to compensate?
Has the pump higher, and therefore the myocardium
Hypertrophies, becomes larger, right? It's trying to push out against resistance, so it becomes larger. That happens over time, right? But if we're dealing with an acute episode, that heart has not compensated for that. So you're gonna see a more dramatic patient with more symptoms, unable to compensate and decompensating. Hypertensives are different, and remember, hypertensives, when they are dealing with higher pressures, they're used to it. So when you have patients who are hypertensive and have had an insult to their cardiac system, what might seem as a normal pressure for you may not be normal for them, because they perfuse at a higher pressure, and it's almost like for us, it doesn't make sense that we want to keep the pressure higher, but we might have to keep the pressure higher on those patients. But on someone who, you, me, anybody here who's not hypertensive, and if we had a cardiac event right now, we don't have that compensation, right? We don't have that time to, that the heart's had time to figure out how it's going to compensate to deal with that pressure. Any questions on this part? You good? All right, so here we talked about the early ejection, where it's going to open up the aortic and pulmonic valves, because it's not only the mitral and tricuspid, that goes from atria to ventricle, but then aortic and pulmonic goes from the heart to the body and the lungs, right? Okay. And then the late, which is gonna give you the rest of the total ejected volume, and then it starts all over again. And here's a arterial waveform, and it's kind of showing early systole, late, dicrotic notch. Here's what I want you to remember. Remember, I'm gonna repeat some stuff. The dicrotic notch signifies the onset of diastole. When do we inflate that balloon? At the notch. So when are we inflating the balloon? At the onset of diastole. Remember, Naomi, what did we just say? The dicrotic notch is when? What does it signify?
The starting of diastole.
Diastole. Kim, when does that balloon inflate?
On the chronic notch.
Exactly. So, and the better the pressure, the crisper the knot. If the patient has a not so hot pressure, you're not gonna have a really pretty notch, right? And I'll tell you what we used to do, and I don't know if they do this anymore, and it's a little bit different now because of the balloon, but if we had a patient who we couldn't see a notch, we would assume the notch was a third of the way up, and that's where we would inflate. Because every once in a while we would see that, okay? So I'm really interested to see how the balloon that does autopilot figures that out. Because when we used to have to do all the timing, that's what we used to do. So the better the pressure, the nicer you're gonna see a crisper waveform and a nicer notch. Okay? And here's putting it all together. So your electrical and your mechanical. Remember, you can have electrical with no mechanical, but you can never have mechanical with no electrical. And if you have electrical with no mechanical, you essentially have no pressures anyway, so you still have to figure that out. But again, it's just what you're seeing on an EKG. So again, remember that an EKG in and of itself doesn't really tell you the contractility of that heart. It just tells you the electrical activity. Okay, here's where we get into the good part. Hemodynamics. The ICU nurses all know this is a review, right? But I want you to remember this because this is important as far as what we're trying to achieve. These are the endpoints we're trying to achieve. Cardiac output is stroke volume times heart rate. So if I'm multiplying my heart rate, normal heart rate is what? 60 to 100. 60 to 100, right? So stroke volume times heart rate equals cardiac output. If my heart rate is so rapid, then what do you think is going to happen to my stroke volume? To a point, but then no. Then it's going to drop because my heart has to keep up, right? Okay. Initially, you're right. Because if I'm running, right, my heart rate is, and my stroke volume has to keep up, right? But if we're talking about a heart that's like over at 100 at rest, not the same thing, right? Not the same thing. So normal cardiac output is 4 to 8 liters per minute. So there's different ways to measure that. Do you guys put in swans ever?
No.
Right. So a Swan-Ganz catheter is a way that we measure it by doing thermodilutions. And then there's very sophisticated continuous cardiac outputs that you'll see in CTICUs, and we used to use them. And it's nice because they just give you the continuous cardiac output. But I just want you to remember that normal cardiac output is 4 to 8. But the holy grail here is the stroke volume. What am I putting out that is going to perfuse everything and keep everything functioning? So, normal stroke volume is 50 to 100 mLs. Now, cardiac index. Cardiac index is cardiac output divided by body surface area. So which number is more important, the index or the output?
You said the other day the index, right?
Oh yes, Naomi, you remember. Yes, the index. You know why? If I'm a 6'4" guy weighing in at 220 pounds and my cardiac output is 4, and I'm a tiny little nurse here who's like what, 5'2", weighing 100 pounds, 110 pounds, and my cardiac output is 4, are they the same? No, because we're saying that this body surface area is the same as the body surface area of someone who is like half the weight and much, no, not the same. So cardiac index, normal is 2.5 to 4. When we get below 2.5, 2.2, we're going into a little shock there, situation here, which we don't want to be in. So again, if we measure cardiac output, we can easily figure out the index by knowing the patient's body surface area and doing this calculation, okay? Easy, and we can figure out the index. And remember, it assumes no regurgitant flow. It means we're assuming that blood's moving forward here, because if blood's moving backwards, then this is skewed, okay? Questions? Okay, ladies, moving on. So, here are the things that we want to make sure we understand, because these are the things that with the balloon, we're going to be counting on all these things to be working correctly so we can get the best augmentation from that balloon. Stroke volume is affected by the preload, the afterload, and the contractility. So, what is preload? Anybody?
Is it when the blood goes out of the ventricles and also to the body?
We're talking about the ventricles, but we're looking at what is in the ventricle at the end of diastole, before systole. Left ventricular end diastolic pressure, same as preload, okay? So when we're looking at, so if we had a Swan-Ganz catheter, right? And we are looking at that pulmonary pressure, that pulmonary artery pressure, we're looking at this. We're looking ahead. We floated and we're looking ahead to see what is in that ventricle before systole. That's the preload. So if I'm in so just think about this. If I'm in hypovolemic shock, is my preload high or low?
Well,
It's low, right? Because I have less volume, right? So if I'm in heart failure, is my preload high or low?
No, it should be high.
High.
It's high, exactly, because the other factor here that's not helping is contractility. So preload is what's in the ventricle before systole that we're looking at, left ventricular end diastolic pressure. Afterload, we already said, is the resistance the heart has to pump against. So if my resistance is high, my heart has to pump harder. So that's not good because I'm using more oxygen. And if I already am having an MI or ischemia of some sort or chest pain and haven't had that MI yet, I'm still taxing that myocardium. So again, I don't want to pump against a higher resistance. I want to make the work as easy for the heart as possible, right? And then contractility, the muscle itself. Is the muscle able to contract? If your patient has cardiomyopathy, those hearts don't contract so well, right? And the patient can end up having minimal contractility, and we have to try to fix the other numbers, but what can we do about that heart? There's drugs, there's other things that can be done, and sometimes the end result is a heart transplant, right? And believe me, they get done a lot. They get done a lot. Just go right down to North Beth Israel, and you'll see. We do a lot. So again, preload is, what did we say preload is?
The pressure in the left ventricle during diastole.
Yes,
What's in
at
the
the
ventricle before systole?
exactly, before systole. Left ventricular end diastolic pressure, same as preload, right? And then afterload is,
The resistance that the heart has to pump.
has to pump again, right? So again, if we have a hypertensive person, right, not controlled, that resistance is higher, right? All of us sitting here, hopefully nobody's hypertensive, but we're good, right? We're good. And then contractility, the strength of the muscle, right? The strength of that muscle. I'll give you a quick story. Years ago, I'm talking about 1989, okay? Back then, a lot of young people, especially young men, were using steroids to pump up the muscles, to get, you know, pumped up. And we had a case, this was one of this, I'll never forget this case because it was one of the saddest things I ever saw. So there was a young man, he was about 18 years old. And he was, you know, slender. He wasn't a pumped up guy. And he got tired of not being one when everybody else around him, you know, all the guys were more athletic. So what did he do? He was going to the gym, but he started to use steroids. So what are the steroids supposed to do to the muscle? Why do they take the steroids? Go ahead.
Makes the muscles really big.
Yeah, increase muscle size. What's the heart? A muscle. So the steroid increased the size of the heart muscle, but not the force of contraction or the contractility. In essence, he ended up with a 90-year-old's heart, just about. We had him on a balloon pump. We had him on drips. He was with us for 2 weeks, and he passed away waiting for the transplant.
What was his ejection fraction?
His ejection fraction was 20. So normal ejection fraction, guys, 55 to 60. So 60 is the number we like. He was down to 20, and I think even a little bit lower than that at one point. But the saddest part of all was that there was really nothing. We had every possible that we were going to transfer him. He was starting to get better, and then he got worse and better and worse. But the bottom line is he ended up dying just before transplant because the contractility, even though you made the muscle bigger, bigger wasn't better, right? It was ineffective actually. So again, preload, afterload, contractility. And then remember the other component of cardiac output is heart rate. So we want to make sure the heart rate is affected by different things. The endocrine system, the central nervous system, the baroreceptors, the pacemakers. So the central nervous system, your parasympathetic, sympathetic. So your sympathetic is your what?
Your fight or flight.
Fight or flight, right? You know, you're driving to work, you're half asleep, you drive the same thing, somebody cuts you off, woo, you're wide awake now. That heart rate's racing, you're like, you know, that's your sympathetic system. Your parasympathetic, rest, relax, and digest. That's how you're gonna remember that one. That keeps everything nice and calm. Baroreceptors, you have them in the carotid and the aorta, okay? And then the vessels and the pacemakers of your heart. The SA node, the AV node, and the ventricles, the Purkinje fibers, those are the pacemakers. The further down you go down those pacemakers, the worse the problem is. So all these things are going to affect your heart rate, all right? We good so far on components and what affects cardiac output? And remember, the aim here is a good stroke volume. We need the stroke volume that's going to support whatever it is we're doing, right? Oh my God. So this is exactly what we just said. And if you had a Swan-Ganz in, you can measure this, and these are the numbers. So left ventricular end diastolic pressure is pulmonary artery pressure. It's the same thing. That's your preload, same thing. So if I say to you preload, or I say left ventricular and diastolic pressure, or I say pulmonary artery pressure, we're all talking about the same thing, right? And that number is 4 to 12. Pulmonary capillary wedge pressure is even a better indicator of what's in the left ventricle at the just before systole, and that's between 4 to 12 as well, plus or minus 4 from whatever number the pulmonary artery pressure is. The CVP pressure is a little bit lower because we're talking about above the ventricles, right? We're looking at the CVP, we went, subclavian, and we're just hanging out just before the right atrium. So we're looking higher where the pressure's not as high. So again, all of these things are going to determine what your stroke volume is going to be. And you see where it says stretch of the ventricles there? We're going to talk about that stretch and how that stretch is going to help in what it is that the patient needs. Again, we talked about what afterload is. It's the impedance to the ventricular ejection. What's the resistance? It has to overcome the aortic and diastolic pressure and the resistance of the arterioles, systemic pressure, right? Now, how can we measure it? We measure it by system vascular resistance, SVR. SVR is normal 900 to 1200. There is a formula to do SVR, and we used to calculate it all the time. And it was MAP minus CVP times 80 divided by cardiac output gives you your SVR. So I think now you can, when you do it, it automatically can come up. But that number is going to tell you what's the resistance the heart is working against, okay? Are we good with preload and afterload? We understand what we're looking at, right? Good.
Could you repeat that calculation again?
Oh, okay. Hopefully you'll never have to do it. It's MAP, so you have to calculate your MAP. So your MAP is the systolic plus 2 times the diastolic divided by 3. So I get a number like 60, right? 60 times 80, which is a constant, right? 60 minus CVP, which you have to have the CVP, so that's 50, times 80, which is a constant, divided by your cardiac output. And that will give you a number, hopefully within here, but it could be less and it could be more, right? So if it's low, what are we thinking? If it's really low, what are we thinking?
Hypotension.
Yeah, right, we're thinking everything's dilated, right? Possibly shock. And if it's high, what are we thinking?
The opposite.
The opposite, or it could be shock as well, because remember in shock, everything clamps down. So, depends on what part of the shock we're looking at. Is it early on or is it later? And again, if it's cardiogenic, yeah, it's gonna be higher. Okay. Everybody good so far? Okay, here's what we talked about, contractility. The ability of the heart to overcome the afterload and to have the optimum preload. Again, ejection fraction. You see this in the cath lab. You measure ejection fraction, and you measure it too also when you do your TEEs, right? And we said here 60 to 70%. So the lower the ejection fraction, the worse. Can it be improved? Yeah. That's the whole point that we're trying to do, is improve ejection fraction on a patient who's had some type of cardiac insult, right? We want to improve that number. And how do we know that this number is improved? How do we know? Forget about anything invasive. Forget about anything invasive. You just have a patient in front of you. How do you know that you're improving?
You look at their blood pressure, the way they're breathing, their extremities.
Right. We're talking about vital signs. Heart rate, blood pressure, respiratory rate. Are they making urine? Are they warm and dry? Are they alert? So all the things, when you look at a patient, that's basically what you're looking at all the time. Is their cardiac output high enough to sustain all the bodily functions, right? When we do all the invasive, really, technical stuff on someone really sick, then we have numbers to back it up. But don't ever get away from just assessing the patient and how the patient looks. Sometimes a patient looks much better than what the numbers say, and sometimes the number looks good and the patient don't look so good. So you got to go by what you are seeing and what the patient's telling you, what the body's telling you, okay? Okay, let's go to the next one. So here's again, remember I said before, I want you to remember supply and demand? This is it, supply and demand. So supply is oxygen extraction. What are the tissues extracting? that I need. And we measure that with SVO2 monitoring too. That's another nice thing that we monitor as well. So what is the supply? Diastolic time. Remember, the shorter the diastolic time, the less blood I'm able to supply. So tachycardia, shortening diastole. All those situations, I'm supplying less. Diastolic pressure, again, coronary artery flow. This is the part that you guys look at every day. What's the coronary artery flow? Do I have an occlusion? Do I have more than one occlusion? Is it proximal? Is it distal? Blah, 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 blah. Do they have symptoms? All these things, that's what we're looking at. And demand is going to be the preload, the afterload, the heart rate, and the contractility. Questions? Any questions from the ladies out there?
No.
Thank you. And here's the anatomy of the coronary artery, and we all know, because you've seen this a million times already in the cath lab, right? The right coronary, the left main, the left ascending, the circumflex, and then we have the distal branches. So all of these things, the posterior, all of these arteries are the arteries that are being affected. Now, I want to tell you something. Why is it that, I'll give you a scenario. We have a 65-year-old, make him 65. 65-year-old has a heart attack, right? Well, but not even a heart attack yet. 65-year-old's having a major ischemia. Looks like they're gonna, but they're awake and they're alert. And other than this little funny chest pressure that I'm having on and off when I go up and down the stairs, and if you live in my house, you go from the attic to the basement 10 times a day. I go do the wash, and I gotta come up and I gotta sit down, or blah, 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 right? That person has an MI. However, sitting there and you're saying, oh my God, how did this person have this occlusion? Because it's not like a sudden occlusion. And how did they were able to walk around and move and blah, blah, blah. Now, you take that same scenario. I got a 25-year-old, crushing chest pain. 25-year-old, right? All the parts are 25-year-old, much younger body, right? However, much more symptomatic, with much more things going on here, okay? And the patient's not oxygenating as well, blah, blah, blah. What's the difference? Well, location could be one thing, but don't forget I got a 65-year-old and I got a 25-year-old.
The 65-year-old, their heart was compensating for
With
a
what?
lifetime of
With what?
decreased blood flow. With, little smaller arteries.
Collateral circulation, right? Collateral circulation. Don't ever dismiss the value of good collateral circulation, because guess what? Even though that 25-year-old body, we're talking about newer kidneys, newer heart, they might not be able to sustain that insult as well because they haven't had time to build collateral, right? The 65-year-old, no, this has been going on for a while. You just don't have it overnight. The 65-year-old, they've had time, and those collaterals have built up, and guess what? Even though the kidneys are older and everything is older, you're not seeing as much insult. You're not seeing all that dramatic, patient not oxygenating, because that 65-year-old has had a lot of time. I've seen both scenarios, and in both scenarios, yes, the 25-year-old did survive and make it, but they were a lot harder to manage than the 65-year-old. So again, with age comes the joy of collateral circulation. So you have time for that compensate. Remember, the body will always try to compensate for a problem, as long as it's had time to compensate. So don't ever negate the value of good collateral circulation, because that will save a person. So let me tell you one more story. I got a lot of stories. 44 years, I could write a book. So no, but this is a family story, so I'm going to tell you. So remember we said endocrine was one of the things, right? So women, when do they see a lot of cardiac issues? After what?
Menopause.
Menopause. Right, menopause. All us postmenopausal ladies know the answer to that, right? Menopause. And what, we don't have that estrogen protection. Now I'm gonna tell you this true story. My husband's family, before you get married, make sure you get their whole medical history, man, so you'll know what's coming your way. My husband's whole family, big cardiac disease. 3 sisters and him. And the funny part is, my husband's tall, slender. You would never know that he's cooking cholesterol at a, ridiculous rate. It doesn't matter what he eats or doesn't eat. Same thing with the rest of the family. His sister, who used to be a teacher, when she turned 50, she started to have some little chest discomfort. They lived in Bergen County. She went to Valley Hospital. And I was, at the time, I was the manager of the CTICU at St. Michael's. So I don't get involved with families who wants to go to another hospital, because sometimes you gotta kind of let things, So she went to Valley Hospital. And she called me and she said, oh, they did a cath. And I said, oh, how was it? She said, oh, they said I had a little block and they put me on meds. They put her on a lot of meds. And I was like, oh, okay, all right. That was September. December, we all get together for the holidays. I said, how are you feeling? Well, I need 3 nitros to get out of bed, but I can't even get out of the bed to get the nitros. I said, well, you got to change here. You have to, now I said, now you have to come to my hospital for a cardiac cath. So she comes to the hospital right after the holidays. She comes to the hospital for the cath, and they take her in, and I'm thinking, oh, she's probably going to need, a couple of stents or whatever. And the physician who did it, who at the time was our director, calls me over and goes, I go, oh, I thought he was calling me to tell me, oh, we're done with the intervention. She's gonna go to the post-angioplasty unit. No, she needs to have open heart surgery. I said, what? He goes, I'm gonna show you her films. He had the films from Valley Hospital where she did have some occlusion, and she had some occlusion in the left and the right. And then he showed me the film 4 months later of her cath. When I tell you strings, that's all you saw. You didn't see that, you saw strings. She was literally hanging on by collateral circulation. And she had just gone through menopause that year. So whatever was happening, the fact that she went through menopause really accelerated the rate of her disease. She ended up with 6 bypasses. Yeah, so again, women, endocrine, remember, and also remember with women, you don't always get the same symptoms. She had textbook symptoms though. Chest pain, couldn't get out of bed to get the nitro, But again, endocrine, it does affect it. So that's another little family story there that we tell around the holidays. Okay. Let's go on a little bit. Now we're gonna get to principles of the balloon pump and what it does. So we're gonna insert the balloon pump via a femoral sheath, via femoral access. And here, I sincerely doubt it will ever be put in at the bedside. We've put them in at the bedside plenty of times, but here it's almost always gonna be in the cath lab, okay? And again, remember we said you can have a patient who's had a STEMI, comes in for a STEMI. So now the patient comes in, having a big heart attack, blah, blah, blah. The doctor goes in and he says, you know what? We need a balloon pump. This patient needs a balloon pump. Get the balloon pump, blah, blah, blah. We could also have a patient who is not presenting so dramatically, but when he goes and he does the first the left-sided shot in the cath lab, he sees that the left main is pinched, blah, blah. Again, you want to support until bridge to intervention, right? The intervention here is going to be open heart surgery. You're not going to do any crazy left main here. Patient's going to go for open heart surgery. So again, we're going to bridge to intervention. So we can use the balloon pump as therapy and as bridge to other therapies, right? So it's showing you here where the balloon is going to be inserted. It could be inserted in the left or the right. So if we know that the balloon has to be inserted via the femoral, what's going to be some contraindications that we can't insert it?
If they're anything
Peripheral
like
vascular
flat.
disease.
Peripheral vascular disease, what else?
If they're unable to lay flat.
Well, unable to lay flat's not gonna be a thing, because if the patient has to be sedated, the patient has to be sedated, the therapy outweighs the ability to, you know. But peripheral vascular disease, if he's got peripheral vascular disease, there's no way you're gonna get that sheath in, right? Right, not gonna happen. So, again, and a couple of times we also put the balloon in directly into the chest in the OR. So that's something you're not gonna see so much, but it can be done. See all the fun things that you could see? So, you see this volume displacement we talked about here? So remember upstairs, let me go to the next one. Remember upstairs, we looked at the inflation, deflation, inflation, and I said to her, put it on 1 to 2. We want to see an assisted beat and an unassisted beat. And when we saw the unassisted beat versus the assisted beat, on deflation you see that it dips down. That dipping down is that displacement is what's decreasing the afterload. And that's one of the effects we want from the balloon. So 2 big effects we want is increase cardiac oxygen to the vessels, right? And decrease afterload. 2 of the big things. And here's placement again, and verification of placement. So here, when you have a balloon pump in a patient, you will well, obviously in the cath lab you're under fluoro, so you can't get much more, you know, verification. But every morning the patient has to have an X-ray because it can migrate. Okay, and we said you're in here and you're going to what the first to second intercostal space was just the beginning of the subclavian, right? But if the balloon migrates down, you're going to cut off the renals, right? And if it migrates up, you're gonna block the subclavian. So every day there has to be an X-ray done. So, and it has to be reviewed. Inflated, these are little. All right, the size, let's just look at the size. In this hospital, we have a 30 cc and a 40 cc. We do not have a 50 cc. So again, it's gonna tell you the patient's height and the body surface area. For the most part, the population will use 40 cc's. Okay, you might get someone very tiny who needs a 30 cc, or what?
Like, I'll be the height
You'll-
for a 30 cc balloon.
You'll have you want to claim the 30 cc balloon, it's
No,
all
I do
yours,
not want
Kelsey. And then a 50 cc's for somebody, but we don't have a 50 here, guys, so the person's bigger, you're gonna use the 40, that's it. I have to ask them how much it is now, because it used to be $800 per catheter, but that was years ago, so I'm sure it's much more expensive now. Inflation. We're going to inflate at the start of diastole. We're increasing coronary blood flow, increasing diastolic pressure, and we are increasing coronary collateral circulation. There's that collateral circulation again. And improving systemic perfusion. And that's the goal, to improve systemic perfusion, right? To get all those organs perfused. Remember this, mean pressure has to be higher than 60, 65. That's what we're aiming for. Don't worry about what you get in. If you have a patient on a balloon pump, don't even worry about taking blood pressure, because you got a catheter sitting in the aorta and you can't get much more real pressure than that. Because I don't care what the left arm and the right arm are showing me now. Doesn't matter. I want to know what the pressure in the aorta is and what that mean arterial pressure is. Okay? Deflation. Deflation at the onset of systole during the isovolumetric contraction phase. We are going to decrease afterload, shorten the contraction phase, increase stroke volume, and enhance forward cardiac output. And the reason we want to shorten the isovolumetric, God, I can't get that word. The isovolumetric contraction phase is, we said, myocardial oxygen demand is the highest during that time when the tension's building. So if we shorten that, then we shorten the need for all that myocardial oxygen consumption, right? Decrease the afterload, decrease the resistance. Everybody understand so far? We're good with this? Ladies out there?
So during the deflation, that's when the heart beats and it increases the peripheral circulation.
Right, so you're displacing the
So
volume.
for that,
So if I have
half
a,
a second,
yeah, so it's as many times as your heart beats,
Yeah.
exactly. So we're displacing whatever the volume of that balloon is. So if it's a 30 cc balloon, we're displacing 30. If it's a 40 cc balloon, we're displacing 40. And as we do that, with every beat, we are decreasing the afterload, okay?
are
And
you
here,
gonna use it if somebody's got aortic regurg?
no, good point, because contraindications we didn't get to yet, but that's a contraindication. If I have aortic regurg, I can't put in a balloon pump. Can't do it. Or aortic stenosis, can't do it, right? Because I got that mechanical problem now, it's not gonna help me. So, good point, these are contraindications. We talked about peripheral vascular, but you got aortic regurg and aortic valve disease. Signs of clinical improved condition. Now this you're very aware of. Increased cardiac output, increased urine output, decreased preload, decreased pulmonary congestion. So how are we going to measure that? How are we going to know there's decreased pulmonary congestion?
So now listen to the lungs.
Yeah, we're going to listen to the lungs and we're going to look at oxygenation, right? If oxygenation's improved and the lungs sound clear, then we're cooking. Improved mentation. The patient is awake and alert. Remember, always mentation is very important because one of the first signs of hypoxia is confusion, and people don't relate that always. Somebody's confused, oh, they're confused, they're in the hospital. Sometimes it means more than that. Decreased heart rate, because the heart doesn't have to beat so fast to get the blood pumping out. The heart will always compensate for the need for more, it will always compensate the stroke volume for the need. Remember, supply and demand. If you're doing exercise, what happens to your heart rate? It goes up because the body's like, well, I need more. Gonna bring it up, okay? Decreased lactic acidosis if you're measuring lactic acid levels, increased pulse pressure and pulse rate, decreased signs of myocardial ischemia, increased coronary blood flow, decreased afterload, and decreased oxygen demand. And also, again, you're gonna look at the patient and you're gonna see what's the color, warm and dry, all these things that you normally would look at a patient, same thing. Sometimes you gotta, like, all of the things that we do, all the lines we put in, just look at the body and see how the body's responding, right?
Not on there, it increases nitric oxide.
Okay.
Yeah. Now it decreases the preload because, it increases coronary blood circulation because it decreases the preload.
Yeah, because you're also giving oxygen to the coronaries, increasing oxygen during diastole, which is when the coronaries get their blood flow. Now, indications, everything we talked about. Acute coronary syndrome, STEMI, complications of heart failure, cardiogenic shock, somebody who's got cardiomyopathy. They used to use it years ago just on plain old shock. I haven't seen that done unless it's cardiac related. Cardiac and non-cardiac surgery. So as a bridge to cardiac surgery, like I said, we're gonna put it in a patient until we get them to the OR to support the patient. Okay, and we know what this is, acute ischemia and MI. And the goal is to balance myocardial oxygen supply and demand, and there it is again, and support during interventional procedures to address underlying cause. So I have never, I shouldn't say it's not done, but I have never put in a balloon pump prior to a patient going for cath prophylactically. Done it when the doctor shoots the vessels and sees what's going on, then we'll put it in, waiting for other therapies, but never just because. And again, you could put it in and you probably will transfer the patient out. relatively quickly, okay? Okay, again, cardiogenic shock, other complications. I'm not gonna go through all this because you could read this and understand a little bit more of what's happening. And during shock, we know that we're not getting enough blood volume to maintain all our normal functions, regardless of what kind of shock it is, if this happens to be cardiogenic shock. So, and again, if I have someone in cardiogenic shock, the balloon in and of itself is not the only thing we're using. We're going to use drugs. We're going to use medications, drips. We might put the patient on a ventilator. There's a lot of things that are going to be done in conjunction with the balloon pump, not just on its own, okay? Okay, again, it could be used to support patients through various cardiac non-surgical procedures before and after surgery. Again, depends on the place you work at and what they're doing. And the contraindications: severe aortic valve insufficiency, and aortic aneurysm or aortic wall disease. Obviously, I think that's pretty obvious. And then severe peripheral vascular disease, end-stage terminal disease, or sepsis. Obviously, if it's end-stage terminal disease, why do we want to introduce something else if it's an end-stage disease? And severe coagulopathy. Remember I said, when the balloon is pumping away there, it is also destroying platelets because it's beating the platelets up, right? As many times as it's, right? So you want to keep an eye on the patient's bleeding. You might do INRs, you might do PTTs and PTTs. If the patient has, if we know the patient has a severe coagulopathy and they weigh the risks and benefits, it's going to be a tricky, you know, you might be giving a lot of blood products and a lot of factors if we really feel the balloon is going to support the patient. So you're going to be working not just one thing, but several things. You don't know. You don't know and sometimes patients don't even know that they have coagulopathies until something happens like this, and then it happens, right? Again, these are the contraindications, primary and relative. Related cardiac arrhythmias, blah, blah, blah. Incorrect or mistriggering, incorrect timing, and incorrect volume delivery. So in your packet, I gave you, did I give you the timing exercise yet? Oh, yeah. So this is going to be for you to play with later on, to do timing exercises. And the reason you're doing this, even though the balloon does it for you, I want you to know what it looks like when it's not timed correctly, because it's going to affect negatively what the balloon is trying to do, right? So let's look at that a little bit. Let's see where we're at here. So here's some complications, okay? Occlusion of the artery at the site. So occlusion at the femoral. Limb ischemia. So here's the thing. If I have a patient who's on a balloon pump, what am I going to be checking very frequently? Pulses, distal pulses. I should feel a pulse. There should be no, and if you don't feel a pulse, that's a problem. And we had that happen more than one time. And I can tell you, back in the cowboy days at St. Michael's, we would do a fem bypass at the bedside when we had this happen acutely. So again, you want to feel the pulses, make sure everything's warm and dry. And also document how you got that pulse. Were you able to palpate it? Was it a Doppler? If it's a Doppler, mark the X, make sure, because we want to make sure if there's any type of change in that extremity. And here they give you, like, you know, amputation being the worst possible scenario, and loss of function, which thank God I never saw. So when you do your the ICU, when they do their hourly assessments, sometimes even more frequent than hourly. You wanna make sure you do the assessment of the distal pulses. Improper positioning or sizing. So again, remember, if we said we put a big balloon in a small person, it's gonna give us a bit of a problem, because it's gonna, that whole wall of the aorta is gonna be occluded every time it inflates. I've really not seen this, because most times it's average size, right? We're gonna use the 40 cc balloon. And again, we should check the placement with X-ray or TEE to make sure. The problem is, if you really have a wrong size balloon, now you gotta take it out. And now you gotta so it's no easy little thing to do. You wanna make sure you start out with the proper size balloon to begin with. Okay, too large, we said damage, helium leak, damage to the wall, hemolysis. Too small, ineffective cardiac assistance. So if it's too small, it's not really gonna augment anything, because it's not giving me enough pressure, right? So again, go by the recommendations, go by the patient size, and I'll repeat again, we only have a 30 and 40 here in the building, we don't have a 50. Okay, complication, aortic wall damage, aortic rupture or dissection. Forget that, because you know, if that happens, it's over. Only want to think about it. And emboli from dislodged plaque or other tissue. So remember when I told you the story upstairs of one of our surgeons went to remove the balloon, and when he went to remove the balloon, it wouldn't move because plaque formed around it, thrombus formed around the balloon, so he had to take the patient to the OR to remove it. So again, we do never want to leave that balloon dormant in the aorta. The manufacturer says 30 minutes, that you can leave it up to 30 minutes. I would never want to leave it up to 30 minutes, okay? If there's a rupture in the balloon and you see those little flecks in the helium line, you see those little rust-colored or brown-colored flecks, you should see nothing in there except clear condensation. Let me put it that way. And if you see it, you stop the balloon and that balloon has to come out, okay? And there's no other reason why that balloon should lie dormant for any amount of time, because that's when you can get thrombus formation and you're gonna have a big problem. Again, thromboembolism, right, exactly what we talked about. And you can end up with thrombocytopenia because, again, the platelets are being damaged. So the longer the patient stays on the balloon, the greater the chance of that balloon getting a rupture. Because you think about it, we had a patient who was on a balloon for 2 weeks, and at the end of 2 weeks, the balloon ruptured. And we had to remove the balloon. And he wasn't really ready to be weaned, but we left it out and ended up just dealing with the medications. But it's in there constantly. So it finally, that was it. If the balloon does rupture, remember we said you don't throw it out. You put it in a plastic bag and it goes to, you call the company. They come, they send something for you to send it back, and then they do a quality assessment on the balloon. Because if it was something in the manufacturing, they have a whole A through Z of what you do. Of what they do, I should say. Will the patient be anticoagulated if they're on a balloon? Maybe yes and maybe no. It all depends on that patient. There are other comorbidities. Do they have any pre-existing coagulopathies? What's the doctor might put them on heparin, might not. So each patient is different. All right, again, failure, deflate, or ineffective cardiac assist. Again, I've not seen this. The balloon being unwrapped and then rewrapped, you don't have to worry about that. The doctor's gonna look at that. That's for the insertion, okay? You're never gonna have to do anything with wrapping or pulling on that, pulling back on the 60 cc syringe. Never. That's gonna be a physician to do. If they take the balloon out and it's not wrapped correctly, I'm gonna tell you probably 9 times out of 10, he's gonna say, give me another balloon. Because he's gonna feel that there's something probably not right with that manufacturer. It shouldn't be unwrapped, because it's in a tight, sterile package, right?
Do they test the balloon before they put it in?
No. do not. Okay, abrasion with the helium leak, if there's failure of the balloon membrane, if blood is present, we talked about what we're gonna do. Entrapment, extreme question must be, okay, removal. I mean, to me, if you're talking about entrapment, that's what we had that day when we couldn't pull the balloon out because we couldn't get it out, and it had to go to the OR to be removed. So again, and you might not have seen anything prior to that that would have led you to believe that that was gonna happen. You know, like everything could have been going fine and the patient had good pulses and there was nothing unusual or, you know, it didn't have like bleeding tendencies. But when the doctor goes to pull it, if you can't pull it, it's gotta go to the OR, okay? There's no yanking on that balloon to get it out. Absolutely not. I can't really see this, so I don't know if you can see these little flecks. It's hard to see. You see the little dark flecks? Hey, anything like that, you got a balloon rupture. And bleeding is a complication. Again, you want to assess hemoglobin, hematocrit. Patient might need transfusions, other things going on, and infection, which hopefully doesn't happen. I've never seen anyone get an infection from a balloon. Timing. So we're gonna look at timing a little bit, and then I think we'll be done with this part. Again, we're gonna insert the balloon. Where did we say the balloon's gonna go? To what? What's the marker?
Second, third intercostal space.
Beginning of the subclavian, right? It says here radial line. I've never seen one put in via a radial line. Maybe they do it, I don't know. I've always seen it in the femoral line. Here's our waveform, okay? So here's our regular arterial waveform, systole, the onset of diastole at the dicrotic notch, right? And your end diastolic here. So here's your nice waveform. Now here's what I want you to look at. So here's where you're gonna start your inflation. The balloon is doing this for you, right? It's on automatic. But if we get the console that I wanna get, that Felicia's gonna order, we can put that balloon on operator mode and you can practice timing. And it's a good thing to practice, to know, just in case something happens. But it's good for your own education too, so that way you can see does your timing match what the balloon does itself. So again, you want to inflate here at the dicrotic notch, which is the onset of diastole. So this here is what's called an unassisted beat. This balloon is on a 1 to 2, right? 1 assisted, 1 non-assisted. So this is assisted. So we see here what the pressure is and then how much we are augmenting. On the pump, you're gonna see several pressures. You're gonna see an unassisted pressure, you're gonna see an assisted diastolic pressure, and a mean arterial pressure. We are aiming for a mean arterial pressure higher than what?
65.
60, 65, right. Augmented diastolic pressure is gonna depend on the pressure I have to begin with. So let's say I have a pressure of 80 and I augment it to 110. Is the balloon doing its job? It is if my mean arterial pressure is 60 and greater. But let's say it's almost there but not quite. What else can I do to augment that pressure besides this balloon? Medications, right. Either a pressor, inotropes, positive inotropes, vasodilators, all these things in conjunction are gonna be your therapy, not just the pump itself, okay? Not just the pump itself. I want you to remember that because sometimes if we don't get it to do, we need medication. We need that support as well. Now,
Can you explain the 2 to 1 again?
2 to 1.
The settings?
All right, this is nothing. This is your regular A line. This is a 1 to 2. That means a 1 to 2 is every other beat is assisted by the balloon. So this beat, here's the patient, here's the assisted beat. Here's the patient, no assisted. Patient assisted. 1 to 2 is we use for weaning, right? And again, I told you that the doctor has to order that. We can't, even though we know, we think this patient's ready to be weaned, we can't, you know. And usually what they'll do is they'll say, put the patient on a 1 to 2, and let's see how the patient does over the next hour or so. So if the patient's blood pressure stays steady and everything else stays good, then more than likely, your patient's ready to be weaned off the balloon. Now, you see this here, this pressure here, and we can't, right now I don't have a measuring thing here to measure, but you will be able to do this on the balloon if we play around with it. So again, you see what this pressure is. You see the assisted beat and how much lower this is? The difference between this and this is your afterload reduction. So I'm displacing that volume and I'm reducing the impedance to the ventricular ejection. So you want this to be greater than 10 to 15, right? That's what we're trying to aim for. Now it's so nice because the balloon does so much with timing, but we used to have to, there was no automatic timing like years ago. You had to time it and we had to measure to make sure that we were getting the afterload reduction and that we were getting a good one-to-one assist. So the two things we're looking for here, increased coronary perfusion, afterload reduction to meet myocardial oxygen demands and supply. Any questions from anybody on this tracing? All right, so weaning ratios. 1 to 1 is assisted, 1 to 2 is for weaning, 1 to 4. It used to be 1 to 3, and I guess they changed it to 1 to 4. You don't keep the patient on this for too long. Like I said, you'll know pretty quickly. If I start to wean them and their pressure starts to drop and they, you know, their heart rate starts to go up, they're not ready. Put them back on a 1 to 1. So if the doctor says, let's put them on a 1 to 2 for like 30 minutes, and in 15 minutes you see the patient's not compensating, put them back on the 1 to 1. You failed the wean, okay? So again, you gotta keep an eye on everything. And again, it's gonna show you here the assisted augmented diastolic pressure. All these pressures print out on that little printout. You know when she did the printout and had the wave, and we had all of this, and you will use this to document. So you'll take that printout and you'll use that printout to document. So all of these pressures will come out. So again, the assisted end diastolic pressure here and the unassisted, and we want a difference of at least 10, if not the best would be 20, to say that we've improved afterload. Questions on this, anybody? All right, so it's showing you some timing, correct timing, okay? And it's gonna show you some incorrect timing, and then what are we doing if we're doing incorrect timing? We are causing more harm than good. So that's correct timing. Now, the augmentation should be higher than the systolic. So if I'm augmenting a pressure that's low, what I'm augmenting should be higher. That makes sense, right? So just the word augmentation means I'm adding to. So the patient's stroke volume is significantly higher or lower than the balloon volume. If the patient is doing better, then I'm not gonna have such a high augmentation because the patient's doing better. So they're not gonna wean the patient, right? Balloon position is too low. We already said we're gonna check that balloon every day via chest x-ray. And if the balloon position is too low, we're gonna block the renals, and we don't wanna do that. Severe cases of hypovolemia, you are also gonna be looking at how are we monitoring the patient's fluid level. There's, you know, do we have a swan in? Are we just putting a CVP in? What are we doing to keep track? What's the patient's urinary output? What are we looking at to give the patient more fluid? Balancing that with how the patient's cardiac status could sustain more fluid. It's a fine line between optimal cardiac output and pulmonary edema on a sick patient, right? Balloon is too small for the patient's aorta. Low SVR means low afterload. Improper timing. catheter is partially kinked in the sheath, not unwrapped. Again, not gonna be you that's gonna determine that. And the balloon setting is too low. Volume. So somebody messed around with the volume on the balloon. Remember she said you can change the volume of the balloon a little bit? Right. There's really no reason to ever do that. But if somebody inadvertently did that, then yeah, it's gonna cause a problem. But we used to call that fluttering the balloon. Some docs, the way that they used to like to wean the balloon, instead of putting it 1-to-1, or they would flutter the balloon where the balloon was practically not moving, right? But again, remember, the more you do that, the more clots are gonna form, so you don't wanna do that for too long. And here's the goal for deflation: to decrease myocardial oxygen demand for timing and increase the stroke volume. So again, this is unassisted, unassisted and assisted. And you see how this dips down lower? Perfect. It's exactly what we want. We want to see that. The difference between this pressure and this pressure. Okay, afterload reduction. It could be caused by many things. The balloon is not inflated. There's a compliant aortic wall. Improper balloon placement, which again, and partial obstruction of gas. Remember when you kicked off the tube? But you're gonna have an alarm go off and tell you the tube is kicked off. The alarms will be red if it's really important, yellow if it's not so important, and a nice blue to just remind you to do something. So it's a nice little way to alarm. It's very visual. And here's some errors in timing, and after this, I think we're gonna call it a day. And for the cath lab nurses, we have a little thing on the drugs that we're gonna do as well. But we could do that after lunch upstairs. And Kim, don't worry, we're gonna repeat that over and over again. I know you have an appointment. So early inflation, so look at this. This inflation is too early. You see where the notch is? And look where they inflated. So if I inflated too early, then when did I inflate?
During systole.
During systole. I'm absolutely negating any benefit from this balloon if I'm inflating during systole. Because I'm not doing anything for diastole. And I'm actually inflating when the ventricle is trying to do what?
Empty.
Empty, right? Not good, kids, not good. So we don't want to inflate too early. So this, and on your timing exercises I gave you, you have some examples that I want you to play with, and then we'll review them. But again, late inflation. Once again, you're inflating way after diastole already started. So you are not helping. So with late inflation, see where the notch is and see where so are you getting much of an assisted diastolic pressure? Not really. If you measured this, you got nothing. Maybe 5. You didn't assist anything. And you'll see that in the numbers. You're not assisting anything, okay? So again, timing is really important. And I don't want you always, I like the fact that the balloon does it, but I want you to also practice it because I don't want you to get so dependent on things that happen automatically, okay? Things break, and if they break, I want you to be able to do this without that. Late deflation, again, deflated too late. And if I deflate it too late, I increase the afterload instead of decreasing it. Because look, see how high this is? And this is the patient's unassisted. So I'm actually making it worse. So again, late deflation. Early deflation. I'm deflating way too early. And again, if I'm deflating way too early, I'm not achieving the goal that I want. I'm not achieving that nice, crisp, it's going way too early. And again, we have some timing exercises to do. So I gave you all these, and I believe this is where we're gonna end for right now, okay? Does anybody have any questions? Do you understand a little bit better the theory of why we put in a balloon and what we're trying to affect? Remember, the concepts of supply and demand, really important, okay? Really, really important. Especially when you're talking about someone who's had significant cardiac damage. Supply and demand is huge, okay? The things that affect cardiac output. What determines cardiac output? Stroke volume and heart rate. But the holy grail here is stroke volume. We wanna make sure we have enough stroke volume to support what the body needs to do, right? And then the other determinants, preload, afterload, contractility, all these things. So when you think about all this in conjunction and how all this happens with every beat of your heart, then you say, okay, now if my patient has a muscle that's not working so well, everything's gonna be affected, right? It's gonna affect everything, and the outcome is gonna be symptoms. Chest pain, decreased urine output, decreased oxygenation, decreased mentation, all these things that we said we're going to monitor, right? Hourly, maybe even more. And with the drips that we're gonna have on the patient, the positive, so remember, positive inotropes do what? What do they affect?
Contractility.
Contractility. A positive chronotrope affects what?
Automaticity.
Rate, exactly. We're affecting heart rate, right?
Automaticity.
Say, right, so we can have a negative chronotrope or a positive chronotrope. You can either decrease the heart rate or increase the heart rate. Most times we want a positive inotrope to increase contractility. We also have vasopressors, okay? So again, in conjunction, you can have a patient that's on all of them. You can have a patient that's on a vasopressor, that's on a positive inotrope, that's on a vasodilator, which is the most frequent one that we use for cardiac. Hmm? Nitro, right? Nitroglycerin drug, right? So all these things in conjunction. And if we want to wean a patient that's really sick and on a lot of drips, we want to get those drips down to a minimal level, if not off, before we even attempt to wean the balloon. Okay, so that's the order. Any questions, anybody?
Is there any pediatric use?
There is, but I couldn't tell you too much because I never work with pediatric and balloons, but there are pediatric uses for us, yes, there are. You probably would see that at CHOP. Newark Beth does a lot with the peds, and they have a whole peds cardiac cath lab section, and they do a lot. I couldn't tell you if they put balloons in for peds, but there is a pediatric use. Yeah. Questions? Anybody out there?
Are there newer compression devices that are out there?
What do you mean?
Newer mechanical circulatory devices that are as efficient as the balloon pump?
Well, the only other thing that you would do, the balloon pump's been around a long time, but if the patient was really, if you were in a center that really provided it, you put a patient on an LVAD.
Okay.
Yeah, and actually the Impella is a percutaneous LVAD. So that one you'll see used in cath labs that do a lot of, Newark Beth has it, St. Michael's has it. Those are the ones that I know, but an LVAD is another treatment, and that's even more intense. Usually the LVADs are managed by perfusionists. So, any questions? Better understanding? Go ahead, I'm sorry.
When these patients are being picked up and brought to the other hospital, what exactly is going with them? I know, of course, what's in them, but
Yeah,
as
so-
far as the monitor.
That's a good question. So when they come to pick up a patient on a balloon, they will bring their own balloon. And did you guys see the presentation by Gabby on the pump itself?
Yes.
Yes, so there was a part where I stopped her and I put up this piece that was in with the balloon. That's an adapter. It's another tubing. So
Yes.
the other company that used to be Datascope, I don't know what they're called now, Datascope and Teleflex are not compatible in the tubing. So what has to happen is they're gonna come with their balloon, you're gonna hand them that tubing, they're going to attach it to the tubing in the Teleflex. But now, I'm glad you brought up this point, don't forget, this balloon is calculated to give that much helium for the amount of tubing you have and the balloon. Now you're adding more tubing. So it's probably not gonna give, if it was gonna give 40, it might not be giving 40 now. Because now we've added, and I don't know how many milliliters or what it's like, whatever the heck that tubing is, but that tubing is going to add to that. But you are correct in that they will come, they will bring their own balloon, and they will transfer the patient that way.